Thank you. Thank you. Thank you. No, I'm telling you, no. Actually, I just saw Frankie Valli in the Four Seasons Saturday night at the Sovereign Center. Anybody go to that concert? It was unbelievable. Remember him? Yeah, I'm old enough to remember Frankie Valli in the Four Seasons. He was my favorite when I was 7 years old. I was walking around the house singing, Sherry, Sherry, baby. 7 years old. My voice hasn't changed. No. Now I've shared you my problems. We'll talk about yours a little bit. Anyway, scope of the problem. Let's go to the handout, shall we? While Steve fixes the technical end of things. I'm being on camera today, so I have to be less animated than I usually am. So please bear with me.
No, you don't.
Here's some data on the scope of the problem. 50% of individuals with severe mental disorders have a substance abuse problem. That's of interest to people who are in the mental illness business. 30% of alcohol abusers, 53% of drug abusers have at least one serious mental illness. The emphasis is on serious. There are less serious illnesses. Dysthymia, let's say, would be less serious illness. An adjustment disorder, mild PTSD. Serious illnesses are psychotic disorders, severe bipolar disorder. So, of all people diagnosed as mentally ill, about 30% either abuse either alcohol or drugs. So we're talking about something that's not just something that happens once in a while. We don't really, I don't think you need statistics to bring this home because we work in this field and we see this on a day-to-day basis. Although this was interesting, 40% of individuals with schizophrenia also have a substance abuse disorder. It's 4 times as likely as the general population. I have a friend who works down the way here at Wernesville State Hospital and runs a group there. And marijuana is really the drug of choice for schizophrenic patients. They like its effect on their mood. They like that it reduces some of the negative symptoms of schizophrenia and offsets some of the side effects. That and alcohol is pretty much what these patients like to use, and it obviously can cause real problems. Now, we don't deal with a lot of psychotic individuals here, but you may sometime in the future be involved in an outpatient program or an in-hospital program or called to consult to an inpatient hospital program. Somebody with addiction credentials, it's an important service to provide. 61% of individuals with bipolar disorder also have a substance use disorder. Bipolar disorder patients are 5 times as likely to have a substance abuse disorder as a general population. It seems to make sense clinically too. Other data, studies using the Schedule of Affective Disorders, which is more of a research instrument, show that 70% of identified alcoholics also met the criteria for a major psychiatric syndrome, with depression the most prevalent. What seems to be emerging when you look at the data, and you look at the genetics, and you look at the psychophysiology, is that there's these inherited vulnerabilities to a variety of psychiatric disorders, with addiction being one of them. So I think because depression is so prevalent in this population, there are researchers saying, there's probably a form of alcoholism that includes depression, or depression is a close diagnostic cousin of alcoholism. There may be some shared, inherited, and otherwise passed along vulnerabilities to depression. We call it diathesis to depression. But certainly by far here, I guess Dr. Franken confirmed this, probably the most common diagnosis here for our patients, depression. Okay, so you can read these, so you don't have to. In fact, you can read the whole report. You don't even have to listen to me. It's all on paper there for you. Now, we'll just go through some of what I think is the more important points. There's a distinction drawn in the literature between alcoholics type 1 and type 2. They found out recently that there's some it's actually a serotonin antagonist that helps reduce drinking with type 1 alcoholics. Type 1 alcoholics tend to have earlier onset, more severe, shorter course until there's disability, more psychiatric symptomatology, and late onset alcoholics tend to be monosyndromatic, pretty much just addiction, not a lot of comorbid psychiatric problems, and a more insidious course, slower course. Some of the research suggests that monosyndromatic alcoholics, which are type 2, have later onset of drinking, fewer alcohol-related problems, greater social stability, and fewer psychiatric problems and fewer relative to psychiatric problems. The multi-syndromatic or type 1 alcoholics tend to be younger, and they tend to have more personality problems, more depression, more earlier onset psychiatric problems. And I don't really see that much. I don't see the distinction drawn between these two types of alcoholics, this typology, much in psychiatric and psychological reports. We may see it more as the data on this develops, because it's not a DSM-4 distinction. DSM-4 is not really very savvy when it comes to describing alcoholism, making the distinction between alcoholism and alcohol abuse and the subtypes of alcoholism. So that's probably why we don't see that type 1, type 2 distinction in Steve.
All right. There we are. Thanks, Steve. Yep.
I thought this was interesting. Psychiatric severity, not addiction severity, is a better and more reliable predictor of outcome, how somebody's going to be doing down the road, which lends even more importance to paying attention to psychological and psychiatric symptomatology, because it's of prognostic significance, especially it's, the response of the patient's treatment. Relapse to active addiction is high in this population. I think that's pretty self-explanatory. Comorbidity, which is just another word for having more than one disorder, in this case psychiatric. Thanks.
There we go.
Comorbidity can result in poor response to conventional treatment, increased risk for serious medical problems, increased risk of suicide, criminalization, unemployment, homelessness. So obviously it has to be dealt with, and it shouldn't be just dealt with lately. It should be a lot of attention should be paid. Now, in the next section here, the schisms between the two fields. Do people still believe that there's a lot of, I don't know, I don't get to see others, addictions people other than the people here. I do some work in the psychiatric setting. I still find in psychiatric settings that these people don't know much about addictions at all. And they tend to downplay it. They tend to see it as secondary to the psychiatric disorder. Pretty much how you get diagnosed with this problem depends on where you show up as a patient. Show up at a hospital, psychiatric ward, you may get diagnosed with a primary mental health problem. If you come to an addiction center, chances are you're going to get a primary diagnosis of addiction. But the people get a sense there's still a lot of rift or a big chasm between the psychiatry field, psychological field, and addictions. I see some nodding heads. Yeah, okay, so maybe things haven't changed as much as they should by now. I remember when I first got in this field in 1970, and I was put in this training group. I was right out of graduate school. I was like, walking around with my psychiatric books with me, and they put me in this training group with a group of people from St. Joseph's Hospital. Used to have an inpatient place, and everybody in the training group was, most of the people there were recovering, and they had, a lot of them had degrees, and they sort of, went to the College of Hard Knocks, and here I am, and the people from this other agency, all these academic types thrown together, and it was like a rude awakening for me, because I was basically told, you don't know what you're talking about. Your psychology is a bunch of nonsense. This is a disease. And I was naive, and I thought, well, yeah, I know, but psychological factors are often important and sometimes can cause drinking problems. So it was really a weird, well, it was actually a very weird training session, especially when we got into the psychodrug part of it. There was a definite feeling of animosity between, you don't know what you're talking about. You're a mental health practitioner, and addiction's a whole other animal. And I think there's probably still some of that thinking today, but some of it's probably dissolved. A lot of it comes from difference in treatment philosophies and, what gets treated first, how you conceptualize addiction. And these two fields developed along originally similar